The next lecture, we're going to be talking about sulci and gyri. So I'll just skip the sulci and gyri. And let me just tell you that we call this opercular, fronto-opercular region, frontoparietal opercular region, and temporal operculum, because operculum in Latin means curtains. So these are the curtains of the insula. If we remove the curtains of the insula, of course, you're going to be exposing the insula. And we're going to expose the associative fibers that there are just underneath the surface. Okay, so if I remove the curtains of the insula, expose the whole insula, you can see U fibers here, which are fibers that are connected, gyra that are next to each other. And the first association fiber system that you see laterally is the superior longitudinal fascicle. Superior longitudinal fascicle was called superior longitudinal fascicle because its longitudinal is pretty much superior, but has this descending or inferior branch here that comes and gets narrow here. So this is called superior longitudinal fascicle. Now, as I said, you're going to be seeing very different nomenclatures about it. And number one, this was first described by Heil, and he called superior longitudinal fascicle. Then came other authors like Burdak, called the same fascicle, the same system, arcade fascicle, because it goes around the end of the fissure here, arcade fascicle. Now, nowadays, it's more complicated because people who are doing DTIs, they are seeing lots of things that we don't see in dissections. So some people say that the SLF, superior longitudinal fascicle, has 5 parts, other 3 parts, but there are 3 parts that are pretty much well defined. One, that it's horizontal part. Just go from the ventral premotor area that we're going to be seeing later, just anterior to the precentral gyrus down here, until the inferior parietal lobule, namely the supramarginal gyrus mostly. So this is horizontal part of superior longitudinal fascicle. Then you have a second part that is vertical, pretty much vertical. It comes from the inferior parietal lobule towards the middle, superior and middle temporal gyrus, mostly superior temporal gyrus. And you have a narrow thing that goes more anteriorly. And then you have a deep bundle of fibers that go pretty much around everything here. And this is what is being called nowadays the real arcade fascicle. And the arcade fascicle, which is the most deeper one, the deepest one, is the one that is mostly related with the language. Okay, mostly related with the language, particularly with phonoaudiological aspects of language. But anyway, here the idea is to show the anatomy, and I'm not going to show all these fascicles that are being described mostly by DTI. We can discuss about them if you want, but I'm going to show what we can see when you do regular and normal dissections, and that it's something that is reproducible. We can see in most of brains. This is, for example, Katanis. I was just with him last week in London. We did a course together. His concept, this was the cover of the last gray issue, last gray edition. And you can see the arcade fascicle goes around, and then you have this horizontal part, vertical part, and the deepest part, which is the arcade. So you're going to be finding different nomenclature of this. But this is the superior longitudinal fascicle with these 3 parts. Superior longitudinal fascicle. If you remove the cortex of the insula, of course, you are exposing the U fibers that are going from one gyra to the next gyrus of the insula, okay, which is namely the subcortical fibers of the insula, of the cortex of the insula. But it's being called also extreme capsule. It's being called also extreme capsule. If you remove a little bit more, you begin to see the claustrum. But in this view, it's very difficult to dissect the claustrum because it's very thin. But we are seeing here already what is called external capsule, because next step we're going to be seeing the lentiform nucleus. And as I said, external capsule is mostly claustrofugal fibers. Now, if you remove the superior aspect of the external capsule, we can see that we leave two pretty much well-defined bundles they belong to the external capsule that was removed here. We did remove the external capsule, so of course you're seeing the putamen. It was the external capsule of the putamen, as I already emphasized. But you can see now that at the same layer as the other fibers we did remove, we have a pretty much well-defined fascicle here. It goes from the mesial temporal lobe to the basal aspect of the frontal lobe, which is the uncinate fascicle. And posterior to it, you have the IFOF, inferior frontal orbital fascicle. These fascicles are being very much discussed nowadays because of awake surgery. I would say particularly by contributions of Hugues Dufault in Montpellier, France. And he emphasizes that the deepest part of the superior longitudinal fascicle that was cut here, which will be the arcade fascicle, is important for the phonoaudiological aspects of language, while the IFOF, inferior frontal orbital fascicle, that will be coming posterior here towards the calcareous fissure, would be particularly related with semantic aspects of language, which is something, for example, that Catani, that is a professor of radiology, MRIs, DTIs, he's a pioneer in DTIs in London, he doesn't think it is this way. So there's a lot of controversy. And the same about the uncinate fascicle. You see people that say that the uncinate fascicle is related with recognition of faces, other than the inferior longitudinal fascicle that also has this function. You see that you can even listen and read that it might be related with schizophrenia, with autism, with a lot of other issues that it's hard to believe, to tell the truth, because I'm already in my 60s, and I've been seeing anterior lobectomies for epilepsy my whole life, and when going to remove the temporal mesial structures, you systematically cut these structures, and usually you don't have problems. But you have to know that this is the uncinate, this is the IFOF. Let me just come back here. You also see some fibers here that are getting in the putamen, that are coming from the cortex and that are getting in the putamen. I didn't talk about those fibers yet. These are the corticostriatal fibers, fibers that comes from the cortex and gets into the striatum, namely in the putamen laterally and in the caudate medially. These fibers, they do not belong to the concept of internal capsule because they don't go below the superior limit, below the striatum itself. So they belong to the concept of centrosemioval valley, okay, but not to the internal capsule. Corticostriatal fibers. You have lots of corticostriatal fibers coming from all lobes, coming into striatum. If we do remove the putamen, again we see the globus pallidus, and we see the real internal capsule fibers coming from the cortex, going towards the peduncle, or coming from the thalamus, that will be posterior here, and going to the whole cortex. And you start to see the anterior commissure just running at the anterior and inferior aspect of the globus pallidus. We did cut here the superior longitudinal fascicle, the vertical part of it, and the deepest part that will be part of the arcade. And you see that there's a bunch of fibers here. And by knowing that the atrium is here, remember, let me just come back here. I want to go back and forth, emphasize this sort of things. When you look at this, you have to know that the atrium, the anterior horn is here. Thalamus is here. what means that the third ventricle is under here. What means that the body of the ventricle is here. Body of the ventricle is a level above the anterior horn, above. The atrium is in the same level as the anterior horn and the third ventricle. Atrium would be here. Atrium is very posterior. That's why when you're dealing with tumors here, you're very easily getting into the atrium. Okay? So anterior horn, thalamus, and body of the caudate also here. Okay? And atrium will be here. And so you know that the inferior horn will be here. So what I want to emphasize that removing the superior longitudinal fascicle, we're going to be seeing a very well-defined bunch of fibers all together here. And the I4, for example, is continuous with, it's part of this big bunch of fibers that we have here. Also the uncinate, but the uncinate goes anterior in the temporal lobe. And here you are. Now, we're going to be seeing now different fibers that constitute this bundle here, all these fibers all together, that Joseph Klinger in the 30s, I'm sorry, in the 40s, 50s, and 60s, mostly in the 60s, in the 1960s, he had his book about white matter dissection. And he was the one that made popular the fiber dissection technique, freezing the brain and so forth, as you know. And Professor Yassergill did study with Joseph Klinger. Klinger was not a doctor. He was a technician in the lab, but he did beautiful dissections, and he has this very, very known book, famous book of fiber dissection. And he called this the sagittal stratum. Sagittal because it's sagittal. Stratum that means different layers, many layers. I think this is a very appropriate name, and I've been using this name, sagittal stratum. And all these fibers, we're going to see all its components. They are covering laterally the atrium and the inferior horn. I know that the atrium is here, and the inferior horn is just underneath the central core, underneath the insula. Very important. We go there very often. So here, to start, we can see that the I4 fibers, they come from the inferior aspect of the frontal lobe and go towards the occipital lobe. Inferior frontal occipital fascicle. Okay? And you have the uncinate. They belong to this most superficial layer of the sagittal stratum, underneath the superior longitudinal fascicle. Here you see all the sagittal stratum. And here you can see very well that the I4 is pretty well different than the uncinate fascicle. But now we are going to be seeing this space, which is very important space. You see the globus pallidus. And you see here, believe me, this is the ventral striatum. To see this, we did remove the putamen. And here, anterior, you have the ventral striatum, the nucleus accumbens, that medially will be continuous with the head of the caudate. Globus pallidus, anterior commissure. And here you have the fibers of the anterior limb of the capsule. And what is this thing here that you have this multiple perforation? What is this thing? What is this? Anterior perforate region, anterior perforate substance. Anterior perforate substance is this floor of what we're talking about. Of course, where the lenticular striate arteries come to. So we see in this region that has many different names. The old German anatomists used to call this region here this innominate substance region, substantia nominata, because they didn't know what it is, what it was. So the term innominate substance region, is very much related with the anterior aspect of the pallidus, globus pallidus, and the ventral striatum. That's what they referred to. Leonard Heimer started calling this ventral striatum pallidal region, which is a good name. But there are some people that are calling this region anterior perforate substance region, which is, I think in neurosurgery, this is the nomenclature that we'll have most. Anterior substance itself is the wall itself. But when we say anterior substance region, we're talking about all this region that is also called ventral striatum. We're going to be seeing in a lecture that this is the temporal stem. This is the temporal stem. So the temporal stem is continuous with the ventrostriatal region that will be medially continue with the septal region. We'll return to this. This is very important because insular tumors go through here. And neurosurgery is not being able so far to get inside this region, particularly because of the small arteries we have here. But we have at this point to understand what is this region. When you read substantia innominata, or you read anterior perforate substance region, or ventrostriatum region, we are referring to this region that is medial to the temporal stem, which has posterior the globus pallidus and the anterior commissure, as its floor and anterior wall also the anterior perforate substance, as its medial limit, the nucleus accumbens. Nucleus accumbens, indeed, is inside this region we're talking about. And inside here, you also had the magnocellular nucleus of Meinert, the cholinergic nucleus. That's being very much studied in Alzheimer's disease because it gets smaller, it's atrophy in this type of patient. It also belongs to this region. If we remove the anterior wall and the base, namely the anterior perforate substance itself, you're still left with the accumbens. You're still left with the anterior commissure at the base of the globus pallidus in anterior limb fibers of the internal capsule. And you see beautifully here all the sagittal stratum. We've seen the most superficial aspect of the sagittal stratum. We did remove, let's come back here, we did remove the IFOF, we did remove the uncinate. Okay, so we see better the anterior commissure. And you see that the anterior commissure have fibers that come anteriorly here, but they also go posterior. So the anterior commissure is another layer of the sagittal stratum, pretty much together with the IFOF and the uncinate that were removed here. You can see here anterior commissure, the fibers of the anterior commissure. IFOF fibers were sort of removed. We're going to be seeing this later. If we cut the commissure, the anterior commissure, and peel, when we cut this, let me come back here, I peel these fibers from the anterior commissure, remove them, I'm going to see inferiorly another layer of fibers that are coming from somewhere posteriorly, do a loop anterior and go posteriorly. This is the most inner fibers of the sagittal stratum. To get here, I did already remove the IFOF, the uncinate, and the anterior commissure fibers that were coming here. This is anterior commissure that was left. What fibers are these? Optic radiation fibers. Okay, optic radiation fibers. We're going to be seeing better that they come from the lateral geniculate body region. And this is the anterior commissure. You see here the head of the caudate. You see the accumbens. So this is the ventrostriatum that puts together the head of the caudate, accumbens, and the length, the putamen that was here, that was removed. Okay? And down here, what do you have? This is head of hippocampus. So what is this? The amygdala. So let's continue. When you remove the anterior commissure, you see that the anterior commissure is always inside a groove that there is under the anterior part of the globus pallidus. And this groove is called channel of Gratiolet. Louis Gratiolet is one of the most important neuroanatomists, France, in the last half part of the 1900, and he's the one that described that the Socin Jari have an organization. We'll come back to this later. But he was the professor of Paul Broca, who did a lot of contributions to neurosurgery, Broca area, and cranial-cerebral relationships. So we're going to return to this. And he was made very popular by Paul Broca. So this is called channel, and Gratiolet was one that did describe better also the optic radiation of Gratiolet. Okay, so this is called channel of Gratiolet. And returning to this, as I said, anterior commissure is not important functionally anymore. If functional surgeons that are here, if I'm saying if something different, please do correct. But I don't see any very important function related with the anterior commissure. But it's a very important anatomical landmark. You see being used very much in neuroradiology, okay, and also in anatomy. The old anatomists, German anatomists that describe the innominate substance, they did refer what is ventral is what is related with the anterior commissure. This is ventral pallidum, and this is ventral striatum. So these two together, this area they call innominate substance, they didn't know what it was related. But we are studying morphology here, architecture. So at this point, I want to show again that the amygdala is continuous superiorly with the globus pallidus. I never saw such a dissection as good as Richard's, but you see here that it's completely continuous. That's why epilepsy surgeon says we don't remove the whole amygdala, because the amygdala doesn't have a real limit, you know. It's pretty much, and you don't remove the superior aspect of the amygdala. That is hard to remove surgically. But you have the channel graciole, anterior commissure, ventral striatum, ventral globus pallidus, and this superior extension of the amygdala. And posterior to this, you have, this is all optic radiation. Of course, as Touré, probably you heard about Ugur Touré, a great surgeon of tumors and many other things. Now he's in Istanbul. Yasargil is the most important disciple of Yasargil. And I think that he's the one that understands most about neuroanatomy, surgical neuroanatomy nowadays. And he is the one that made more popular this fiber dissection techniques described by Klinger. And he gives courses all around the world. I think you should do his courses when you can. But he always emphasized, it doesn't mean that this is optic radiation. These fibers are all together. They are intermingled. But at this point, most of these fibers we're talking about here are optic radiation fibers. Okay, this is a beautiful view, again, of what we're talking about. Let's see the normal side before dissection. You have here the anterior perforate substance. Okay, you have here the anterior perforate substance. And you know already that this is the base and anterior wall of the region we're talking about, which is the ventral striatum region. Optic olfactory tract, and you have medial stria and you have lateral stria. Medial stria and lateral stria are the anterior limits of the anterior perforate substance. Because in tests, you're going always to find what are the limits of anterior perforate substance. Dr. Rotten used to like very much to mention all these things. So the anterior limit of anterior perforate substance, medial and lateral olfactory stria. The medial limit is the interhemispheric fissure itself. And the most lateral limit is the liming insula we're going to be seeing later on. Liming insula, almost here at the base of the stem of the Sylvian fissure. And posterior limit is the optic tract. Posterior limit of anterior perforate substance is the optic tract. Everything that is posterior to the optic tract is posterior perforate substance. You see here the interpeduncular fossa. You see that it has where the thalamic striate perforators go through. Everything that is posterior to the optic tract is posterior perforate substance. It gets inside the interpeduncular fossa and also the floor of the interpeduncular fossa. Everything that is anterior to the optic tract is anterior perforate substance with the limits I already mentioned. We're going to remove this and do dissection, and what are we going to be finding here? We're going to be finding here the accumbens, the ventral striatum. And you see here the anterior commissure, and you know that this is globus pallidus because you know that anterior commissure is inside the groove that it's in the anterior and basal aspect of the globus pallidus. And you know that the anterior commissure goes behind the accumbens. This is anterior commissure. Anterior commissure. What is this again? What is this? This is cortex. Apex. What is this? Uncus is the most medial aspect of temporal lobe, right? This is apex of the uncus. This is uncus. So if I remove the cortex of the uncus, what do I have inside the anterior half of the uncus? Amygdala. Believe in what you know. Believe in what you know. This is the amygdala. Now, the amygdala has a lot of efferent fibers, fibers that go outside the amygdala and go medially. All these fibers together are called ansa peduncularis. You probably heard this name or read this name. Ansa peduncularis. Amygdalo-fugal fibers. They are coming outside of the amygdala. And they go towards the thalamus, towards the hypothalamus, and towards the septal region. Let me just mention that the septal region is this most inner aspect of the basal aspect of the interhemispheric fissure. We'll be coming to this next lecture, septal region. Now, ansa peduncularis have three components: the amygdalo-hypothalamic fibers, amygdalo-thalamic fibers, and amygdalo-septal fibers. It turns out that the amygdalo-septal fibers are the most superficial. And you can see them here in the non-dissected side as this ridge that is running across the anterior perforate substance. And this ridge, you see here, this is the same as here. This is the same as here. This is the fibers of the amygdala. They are going towards the septal region. This is called diagonal band of Broca. You probably read this. Diagonal band of Broca are the most superficial fibers of the ansa peduncularis, namely the fibers that are coming from the amygdala going towards the septal region. You can always identify this ridge. If you dissect along this ridge, you're going to get this dissection here. All the ansa peduncularis with all the other fibers. Of course, going anterior and more basal than the anterior commissure. Let's come back here. You see, you see here, again, the anterior commissure, and this is ansa peduncularis. This is ansa peduncularis coming out of the amygdala. Amygdalo-fugal fibers. Now let's see now this continuation of this beautiful dissection. What is this here? Fornix. You have to say it. What is this here? Pardon? Anterior commissure. Again, Theodore Minor. Theodore Minor described that the anterior commissure has two parts. One part is the hemispheric part. This is hemispheric part. Another part is this small anterior part here, which is called the olfactory part. And of course, because this is very old, there's reptiles that I started my lecture here. They needed this. It was their corpus callosum that put it between both olfactory systems. Of course, this is for nothing in our brains now, but shows how important this is and shows the function that this had. It was putting together the olfactory systems in both sides. So hemispheric part of anterior commissure and olfactory part. Beautiful. And of course, this is the lateral stria, this is medial stria, this is the olfactory tract. Okay? This is the anterior limit of the anterior perforate substance that, of course, was removed from here because it was the anterior wall of this that we're talking about. Here we had the accumbens also that was also removed. This is posterior to the accumbens. Remember, this is a little bit of the accumbens that is left here probably. Remember that the anterior commissure goes behind the accumbens and then just at the base of the globus pallidus. Now, you said this is fornix. What is this part here? What is this? This is also fornix. So again, the anterior commissure is a very important landmark, neuroradiology and neuroanatomy. And anatomy, it was a lot studied by real anatomists studying animals, for example. That's why they call rostro everything that is facing down. Since we walk, our rostro is not always rostro, okay? But they describe this as the precommissural fornix fibers and postcommissural fornix fibers. So that's why I said that the most forniceal fibers, they go posterior to the anterior commissure. Where they go to? Where do they go to? To the mammillary body. Now, the precommissural fibers, of course, they will go to the septal region because it's the region that's going to be right here in the cortex, underneath, just underneath the cortex. We're going to be talking about this next lecture, okay? So, indeed, the fornix has a postcommissural component, which is the biggest, and a small precommissural component that Richard showed very well here, that goes to the septal region. This is ansa peduncularis here. Ansa peduncularis there, that we already talked about. Of course, this is the chiasm. And anterior wall of the third ventricle, you said that it's lamina terminalis. In every test, you're going to be seeing lamina terminalis goes from where to where. Lamina terminalis is attached to the anterior commissure and attached to the posterior border of the chiasm. All here, this is anterior commissure. So we can now understand these layers all again. We have to go back and forth. Cortex of insula, extreme capsule, which is the U fibers, the subcortical white matter of the insula, together with a little bit of claustrum. Then external capsule of the putamen. I'm seeing the putamen here. So this is all external capsule. I would have here the uncinate and posterior the IFOF. And these rest of fibers are claustrofugal fibers. And all these fibers get together and constitute the sagittal stratum. Let's see what's next. Sagittal stratum is very thick, very thick. And you can see down there that sagittal stratum are always fibers that go from anterior to posterior. Again, the most superficial are the IFOF and the uncinate. Then you have just underneath the anterior commissure fibers, as I showed. And then you have the optic radiation fibers underneath. And these fibers all together, called sagittal stratum by Klinger. They run underneath the superior longitudinal fascicle that was cut here. And if we go more inferior, more deep, we can see that we have different fibers that have a different direction. Different direction. These fibers, it's what we call the tapetum fibers. Let's see better. This is a posterior medial view. This is the pulvinar pineal region. We went through this. Splenium. You see these fibers very well dissected here. They come from the posterior part of the corpus callosum of the splenium, and they go towards the posterior part of the temporal lobe. Sorry. They are these fibers we're talking about, tapetum. So they come from inside there, from the corpus callosum, posterior part, splenium. They have this orientation. And if you go to old Gray's anatomy, because now when you write to Gray, as I have this distinguished invitation to do, you cannot write a book. You have, of course, a limited number of pages or words. But if you go to very old Gray's editions, you have everything that is about neuroanatomy there. It's unbelievable. And if you look into tapetum, definition of tapetum is the callosal fibers that run underneath the optic radiation fibers. The callosal fibers that run underneath the optic radiation fibers. Of course. You know, you see here, they are running just underneath the most inner fibers of the sagittal stratum, which are the optic radiation fibers. So you understand what the tapetum is. You don't have tapetum here. Tapetum is just covering the atrium here. If I see insula here, again, I know this is anterior horn. I know this is thalamus. Atrium is right here. Atrium is right here. Inferior horn is coming down here. Tapetum fibers. Tapetum fibers. Now let's see, we saw everything coming laterally. The same structures you already saw when we did that, the ansa peduncularis, the anterior commissure. Now let's see everything inside that region again, coming from below. Parahippocampal gyrus, we're going to be talking about details next lecture. Uncus, apex of the uncus, okay? You have a groove here. What groove is this? Here is not this much, but here you have a very well-defined groove. Is this a natural sulcus? You're going to read this in Rotton's papers, many anatomy papers. This is the mark of the incisura, the tentorial incisura. Because the uncus is sitting in the tentorium, and it's very common for you to have this groove given by the tentorium. So amygdala is here, head of hippocampus is here. Hippocampus will be along here. Inferior horn is here inside the inferior horn. Okay? Now, it runs more laterally. Fusiform gyrus, collateral sulcus, occipitotemporal sulcus. Collateral sulcus, very deep and very long sulcus, come from posterior until anterior. Occipitotemporal, just the lateral aspect of the fusiform, interrupted in this case. Fusiform gyrus, I'm going to say next lecture that the gyrus is not a very well-defined structure. A gyrus is a region. Some are very well constant anatomically, other not. Fusiform gyrus always have this tip here, and the tip, it's always at the most anterior level of the brainstem, always. So when you see the tip, fusiform gyrus. You see the tip, I would say fusiform gyrus region. It doesn't go posterior, it's rear. And as I said, the fusiform gyrus is the floor of the inferior horn and of the atrium. So if you remove anatomically the fusiform gyrus, we studied, even in our residency, to do brain cutting. Don't do brain cutting. Brain cutting is for neurologists, for basic neuroscience, for whatever. But surgeons, we want to know the relationships of the structures, where they are. This architecture I'm trying to show. So when you have this opportunity back in your residencies, in your hospitals, try to have a small lab. Go there once in a while and do dissections, but remove gyrus by gyrus to know the relationship. Because as you're going to be seeing tomorrow, most gliomas are inside the compartment, as Asagil told us. They are inside a specific gyro or a specific lobule. So to do anatomical surgery, you have to identify the region of a gyrus. So if you remove the region of the fusiform gyrus, you're exposing the ventricular cavity, as I told. You know, that's just like the boot is always Italy there. Okay, so you see that the anterior half is related with the inferior horn, and the posterior half is related with the atrium. The hippocampus that belongs to the parahippocampal gyrus. I should say that the parahippocampal gyrus belongs to the hippocampus, but the hippocampus, or the Amon horn, is the medial wall, medial part of the floor of the inferior horn. So in order to do this, what did I remove? The collateral eminence and the collateral trigon. Because I know that collateral trigon is the floor of the atrium, and collateral eminence is the floor of the inferior horn. You can have a bigger nose or a small nose, but it's also a nose. That's the same thing. Fusiform gyrus region, always the floor of the ventricle. But one step prior to removing the hole, this is another dissection. Inside the fusiform gyrus, I didn't reach the ventricle yet at this dissection, okay? Inside the fusiform gyrus, you have a pretty much well-defined longitudinal tract. Can anybody tell me what tract is this? Inferior what? Inferior longitudinal tract. Of course. You have the superior longitudinal tract I showed you. This is the inferior longitudinal tract. It runs inside the fusiform gyrus. What means that it runs just at the level underneath the floor of the ventricle. Okay? And if you go studying neurology, you're going to be seeing that the inferior longitudinal gyrus is pretty much related with facial recognition. You have both sides. Now, if I remove everything and expose the roof of the ventricle, another dissection, what is this? Pulvinar, of course. What sulcus is this? Lateral mesencephalic. So what is this? Exactly, medial geniculate body. So this is the Lateral geniculate. So what is this here? Optic tract. You can see here the anterior commissure very well, superior to all these fibers that come from this region here. You see, as I already told you, it comes from the posterior part of the thalamus, the pulvinar, mostly of the lateral geniculate body region. What fibers are these that goes anterior and that go back? The optic radiation. And what's the name of this loop here? Meyer loop. Of course, they cannot come from a single prominence. They come from all this region. And so if you go to very, very old anatomy books, you're going to see that old anatomists used to call this pulvinar part the optic thalamus. Optic thalamus. Because when Gratiolet described that the fibers came, I don't know if this name was given by Gratiolet or not, but they used to call this optic thalamus because this part of the thalamus is always related with the arising of these optic radiation fibers. So they come to the lateral geniculate body. And this is pretty much in the roof now. In the roof and in the lateral wall of both inferior horn and the atrium. No way of getting in the horn, inferior horn or the atrium without damaging the optic radiation fibers. How extensive this lesion will be clinically is something different. Most of the patients don't even perceive they have many of these deficits. But at this point, I want to show that this is in the top of the ventricular cavity. So it has three parts. This is Richard animation, a most anterior part that goes to the inferior part of the calcaneal sulcus. The calcaneal sulcus, or calcaneal fissure, has an inferior margin that is given by the lingual gyrus and a superior margin that is given by the cuneus. We're going to return it to this. And then you have a middle part, and you have a superior part that goes to the upper part of the fissure. The middle part goes more to the lateral aspect of the occipital pole, that it's called the macular vision. So you see the optic radiation, it covers all the ventricular cavity. No way of getting in here laterally without damaging these fibers. But if you do a small damage, mostly anterior, you have a small quadrantopsia, maybe the patient doesn't even perceive. Now let's continue our dissection here. Lateral geniculate body. Lateral geniculate body, you see that it's incorporated in the roof of the ventricle. It's very much in the roof of the ventricle, inferior horn. So this is, what is this then? Optic tract. This area, how do I call this area with these perforations? Pardon? Anterior or posterior? Posterior. You are posterior to the optic tract. Anterior here, you have anterior. This is posterior. This is inferior horn cavity. This is the roof again. What is this? Gray matter in the anterior tip of the ventricular cavity. Ventricular cavity is here. No hippocampus anymore because I'm seeing all the roof. So if I see all the roof, it's because I did remove all the whole floor. Hippocampus belong to the floor. But I would say that this is the anterior wall of the inferior horn. So what structure is this? Amygdala. Okay, this is amygdala. And so this is a posterior extension of the amygdala. What is this here? I told you to. Does anybody remember the name? Exactly, because it's running in between the caudate and the thalamus. This is thalamus, lateral geniculate body. So this is all pulvinar. This is running just lateral to the thalamus. So this is stria terminalis. Now this is roof again. What the hell is this here? Yeah, somebody behind, please. What is this here? What is this here? Gray matter running in the roof of the ventricle. It's not written here. You have to know what is the piece of gray matter that runs in the roof of the ventricle, inferior horn. Exactly, the tail of the caudate. So this is the tail of the caudate. And you see it has the same color as the amygdala. This is amygdala. Remember that the amygdala is not only the anterior wall of the inferior horn, it's also part of the roof very anteriorly. This part here is covering the, if I do more dissection here, I bet that these things they get together, of course, because as I said, the tail of the caudate ends just next to the amygdala, together with the amygdala. And underneath here, you would have the head of hippocampus. Because the superior part of the amygdala, this one that is being showed, and another part that's not shown, is covering the head of hippocampus, okay? And this is all this amygdala is going superiorly towards the globus pallidus, all right? So this is the tail of the caudate. Look how beautiful this is. Again, the tail of the caudate. That's what we were seeing. The roof of the ventricular cavity going towards the amygdala. You see that the amygdala is not only anterior, it comes and covers a little bit the head of hippocampus that is hidden here. And also the amygdala goes towards the globus pallidus. I try to show again for you to come back and put this inside your head. We have to go back and forth. And again, this is the Meyer loop. So when you're exposing the head of hippocampus, which you do very frequently, you went through all this. All the sagittal stratum, okay? You did cut the IFOF, the uncinate, anterior commissure fibers that are coming superior to the optic radiation, and at some extent the optic radiation, if you're going a little bit not only anteriorly. That's why people say that the transuncal approach to the ventricle does not take the Meyer loop, the optic radiation fiber. Yeah, if you go just anteriorly. Again, this is the ventricle, this is the uncus. Anterior half amygdala, posterior half head of hippocampus. This is the apex of the uncus. That will get inserted here, the globus pallidus already. So we come back to the same slide for you to figure. This is already the base of the putamen. So all this thing here we call temporal stem. And this is continuous with inside with the region that we call ventral striatum, or innominata substans, or anterior perforate substans area. Okay, let's finish with this dissection here. The most beautiful hue in the brain is the pars opercularis, opercular part. Always has this beautiful U shape and always harbor inside the precentral sulcus. This is next lecture. The pars triangularis that was removed here is only covering the most anterior short insular gyri. So what I did expose here, what I'm going to be talking next lecture, is the anterior limiting sulcus of the insula, which is very close to the anterior horn. If I go more posterior, I'm seeing here the corpus callosum, body. I'm seeing here the rostrum of the callosum. What is this here, this thin layer here? This is insular cortex, right? What is this gray matter here? Claustrum. So what is this thing here? Bulging in the ventricle? If it's bulging, what's this then? Let's say that this is claustrum, this is external capsule, and what is this? Putamen. If this is putamen, what is this? Caudate. We are at the rostrum. We didn't reach the anterior horn, the interforaminal Monroe. So this is anterior horn. So this is the head of the caudate. And this is putamen. What should you have here? Anterior limb of the capsule, right? But as I said, this specimen doesn't have a real anterior limb of the capsule, just a very small anterior limb. So this is striatum. Accumbens will be here. We'll come back to this dissection maybe tomorrow. So if I go more inside the putamen, I start to see the anterior commissure. This is rostrum, anterior commissure. If I go more, I expose the anterior commissure. You see the anterior commissure looks like a bicycle, how do you say bicycle? The handle of bicycle, yeah. So anterior commissure here. Anterior commissure. Chiasm. So what is this here? Lamina terminalis. This is the going behind the anterior commissure. What is this? Pardon? Yes. If this is pillar of fornix, what do I have just behind? What space is this? Foramen Monroe. What is this here? Gray matter inside the ventricle? Caudate. So this is the body of the caudate because it's already lateral wall of the body of the ventricle. Claustrum, putamen, internal capsule. What part of internal capsule is this? Just next to foramen Monroe. The genu. So never forget this slide. You are just deep to the pars opercularis, and you are at the level of foramen Monroe, and you are at the level of the genu of the capsule. This is septum pellucidum. This is genu of callosum. This is rostrum of callosum. Let me repeat here for you to get already into gyri and sulci. What gyrus is running over the callosum? Cingulate comes here. What gyrus is over the cingulate? Superior frontal. What gyrus is this here? Midline? Very tall, very constant anatomically. The most medial basal frontal gyrus? Gyrus rectus. Gyrus rectus has always, the medial aspect of the brain is very constant anatomically because it's old, very constant. The superior frontal gyrus is always continuous with the rectus gyrus. Rectus gyrus has always the superior rostral gyrus. Superior rostral is facing down, superior rostral, and harbors inside the inferior rostral. Here you have two segments. So every sulci that is inside the rectus gyrus is inferior rostral sulcus, inferior rostral sulcus, superior rostral sulcus. You always have this connection of the cingulate with the superior frontal gyrus. You always have this thing here, this U shape, convolution here, always. Now, when a sulcus ends, is because you have a connection. This connection between the cingulate and the rectus gyrus is another beautiful U. Always have it there, always. Professor Yassar called this the cingulate pole. The cingulate pole. By the way, the best book of anatomy for sulci and gyri is volume 4A of Professor Yassar Gill's microneurosurgery books. 4A, the whole book, almost the whole book about anatomy. Posterior to the cingulate, in between the cingulate pole and the anterior commissure, you have three small gyri. Does anybody remember the name of the most posterior one? Terminal gyrus. And anterior to the terminal gyrus, you have two other small gyri, which are the posterior olfactory and anterior olfactory gyri. This region is also called para-olfactory region of Broca. But inside, particularly the paraterminal gyrus, which is the most posterior one, just anterior to the anterior commissure, you have the septal nuclei. So the septal nuclei are mostly inside the paraterminal gyrus, where the diagonal band of Broca, most superficial part, fibers of the ansa peduncularis, will end, septal region. If you go to anatomy book, you're going to see septum verum, the real septum. Because why real? Because you have neurons here. This is septal region. And this is the false septum, septum pellucidum. Septum means midline, like your septum you have in your nose, right? Everything midline, septum. So this is the septum of the brain. But this is the real septum that harbors the septal nuclei, and this is the false septum. That is just a membrane with gliotic tissue, which is the septum pellucidum. But this is all to emphasize that the cingulate pole is always there, connecting the base of the cingulum, the cingulate gyrus, with the upper part and posterior part of the rectus gyrus. Rectus gyrus is, you're going to read in some books that it's the most constant gyrus of the brain. I read this. It's sort of expected because it's very old. It's related with the olfactory tract. Very old. Now, again, what you had here is the anterior wall of this region is the anterior perforate substance. And as posterior wall, the anterior commissure. All this region here is what we talked about, the ventral striatum, the accumbens, and the structures we saw have at the basal forebrain, inside the basal forebrain. Now I did cut the anterior commissure to show that the fornix going towards the mammillary body. So everything anterior to the mammillary body is hypothalamus. Posterior to the mammillary body is midbrain. Interpeduncular fossa. Roof of interpeduncular fossa is the posterior part of the floor of the third ventricle. Anterior to the mammillary bodies, the floor, anterior part of the floor of the third ventricle. Anterior wall for an anterior commissure to the chiasm. Foramen Monroe, we're left with the thalamus. So the thalamus is the real lateral structure that is lateral to the third ventricle, related with the posterior half of the insula. And if I remove this, I expose the ventricle. So you just expose the ventricle in a dissection like this if you remove the whole thalamus. Anterior to the thalamus, you don't have third ventricle. And we already went through this. These are the arteries. Eduardo is going to be talking about this later on. We went through all this. Okay, just in this, I told you about the relationships of the choroidal fissure with the transverse fissure. It's new concepts for you. But that's how you have to have anatomical concepts. You have to look at MRIs from now on, looking anatomically. Take a normal MRI and keep looking. Study anatomy. Remember a normal MRI. And when you see the tumor, try to understand details of the anatomy of the tumor. I'll try to show some tomorrow. Now, if you open the choroidal fissure anteriorly, okay, you're going to get where? Into the? What cavity is this medial to the thalamus? Don't be afraid. What is medial to the thalamus? What cavity? What? The third ventricle. You open the choroidal fissure anteriorly. Now, to reach the third ventricle, the velum interpositum is just medial to this. Indeed, when you do surgery, usually you go transvelum. When you open the choroidal fissure, you go transvelum because the velum is inside the roof. You go transvelum, the most lateral aspect of the velum, okay? So what I want to show, number one, is that if you open the choroidal fissure anteriorly, you get inside the third ventricle. But you go transvelum. You're going the most anterior part of the transverse fissure. Now, what happens if I open the choroidal fissure more posterior? You see that the crude of the fornix is very flat and is covering all this posterior part of the pulvinar. You see, this is all crude of the fornix. It's a very flat tract here. If you open here, as I'm doing here, where do you get? The pineal cistern. So tomorrow, I'll try to show some ventricular surgery. If you go very posterior, you get transcaloso, for example. If you go very posteriorly, you're not going to the third ventricle, you go to the pineal region. You have to have landmarks where you have to go in order to get into the third ventricle. So remember this, if you open the choroidal fissure anteriorly, you get in the third ventricle. If you open posteriorly, you get in the pineal region. You see there the quadrigeminal cistern. So if you open here, you get in here. This is the choroidal fissure as already shown. This is the pineal region here. This region here is this region here. Eduardo's dissection. We went already through all this. Well, when you open the callosum, how do you know what side, if you're on the right side or not? Very simple rule. You have to look at this major vein. What vein is this? Yeah, and what you have running underneath it? The stria terminalis, right? And this vein goes towards the foramen Monroe. So if the vein is lateral, you're either right in the ventricle where you want to go. In other words, if you want right side, open the callosum, and the lateral ventricle, the lateral striate vein, the thalamus striate vein is lateral, you are on the right side. You are on the same side you enter. If it's the other side, it's because you enter in the other side. What vein is this? Septal vein. If you go to a very old book called Taveras, was professor of neuroradiology in Boston, Harvard, you're going to see that this is venous angle. When I started neurosurgery, you have to see a lot of angiograms, and the venous angle indicates the foramen Monroe. But you have a normal venous angle and a false venous angle. The false venous angle, because this vein here is piercing the choroid fissure, the most anterior part of the choroid fissure. It's not really going around the foramen Monroe. It's opening a little bit. Remember that the foramen Monroe is an enlargement of the choroidal fissure. Anterior border, what is the anterior margin of foramen Monroe? What is this? Fornix, and anterior to the fornix. Now you know. What is the floor of the anterior horn? Rostrum. As I said, tomorrow I'm going to see surgery. You see that the pillar of the fornix is completely continuous with rostrum callosum. Completely. You don't see a margin there. Now, foramen Monroe is an enlargement of the choroidal fissure. So the real venous angle is when they meet at the posterior margin of the triangle. But in many cases, many patients, the thalamus striate vein goes more posterior and gets through the choroidal fissure itself. Then Taveras called this the false angle. So when you see an angiogram, you can see if it's very much anterior, the angle, it's the real. If it's posterior, it's because the thalamus striate vein is getting into the choroidal fissure more posterior. It's just anatomy, just anatomy. Here you see a beautiful venous angle this side. You see the venous angle here. And from the venous angle, the veins go now inside the velum interpostum cistern, inside the roof of the third ventricle, inside the velum interpostum cistern. That's where they are. And all this together is the roof of the third ventricle.